Hello everyone, it's Mimi here. BMS working in the NHS. And today's video will be about gastrointestinal and hepatobiliary histology, which is part of the IBMS specialist portfolio in cellular pathology. So, just a quick introduction to this video. It will be short and sweet, I promise. I will discuss rationale and aims, learning outcomes, indicative content, resources, submission of evidence, Q&A suggestions, some evidence ideas, reflective statement, and some helpful tips to make your portfolio better. With all that said, I hope you will enjoy the content of my video and I hope you will learn a lot. So let's dive into this submodule. Rationale and aims of this submodule outline the general information and expected knowledge and competence that needs to be achieved when this submodule is completed. These are relevant to each submodule. For this submodule, the expectations are that the candidate will gain competence to prepare, process, and stain gastrointestinal and hepatobiliary histology tissue samples. Gain a clear understanding of the pathological basis of disorders of the gastrointestinal tract and hepatobiliary system. Gain a clear understanding of how these disorders may be investigated histologically, have understanding of tissue selection protocols and block selection. Understand the variety and applications of stains used in the investigation of gastrointestinal and hepatobiliary histology. Be able to identify normal and abnormal tissue. This includes anus, small intestine including duodenum, ampulla of Fata, and common bile duct, large intestine and rectum, appendix, gallbladder, and esophagus. The learning outcomes demonstrate candidates' knowledge, skills, and competence in this submodule. They also include demonstration of the understanding of scientific principles, laboratory procedures, quality assurance, and professional conduct. They allow candidate to work autonomously and solve problems independently. Let's explore the first learning outcome, which is for the candidate to discuss how the anatomy and pathophysiology of gastrointestinal and hepatobiliary systems interact. What is the anatomy and physiology of GI system? Consider mucosa, submucosa, muscularis externa, serosa, or adventitia for esophagus, stomach, intestines, liver, gallbladder, appendix. What are the key variations between them to determine their physiology? For esophagus, consider the four main layers: mucosa, submucosa, muscularis externa, and adventitia. Muscularis externa transition from skeletal muscle to smooth to facilitate peristalsis. Transition from stratified squamous to columnar epithelium in GOJ, upper and lower sphincters. Anatomical constrictions: the cervical, thoracic, and diaphragmatic. For stomach, consider four layers: mucosa, submucosa, muscularis externa, and serosa. Anatomical regions: card, fundus, body, antrum, and pylorus. Muscularis externa has three layers to facilitate churning. For small intestine, consider the four main layers: mucosa, submucosa, muscularis externa, and serosa. Regions are duodenum or the mixing bowl, jejunum where the absorption happens, and ileum, plicae-circulars the circular folds. For large intestine, consider the four main layers: mucosa, submucosa, muscularis externa, and serosa. Regions are cecum, ascending, transverse, descending, sigmoid colon, rectum and anal canal, teeny E. coli bands of smooth muscle, haustra, segmented pouches, omental appendices, fat-filled pouches. For liver, consider four hepatic lobes, right, left, caudate and right, 8 functional segments with their own circulation, and ligaments like falciform or coronary, dual blood supply, hepatic portal vein and hepatic artery, lymphatic drainage that can produce between 25 to 50% of total lymph. There is no more room on this slide, but there is also appendix and gallbladder. For appendix, abundant goblet cells, lymphoid tissue in lamina propria and submucosa, simple columnar epithelium. For gallbladder, lack of muscularis mucosa and submucosa. Mucosa has prominent folds, lined by simple columnar epithelium, Rokitansky-Askoff sinuses. How does anatomy and pathophysiology of gastrointestinal and hepatobiliary tissue interact? Consider changes to the structures and the effect this has on the function of the organ. For example, Barrett's esophagus, peptic ulcers in stomach, celiac disease in intestines, cirrhosis in liver, and so on. The second learning outcome is for the candidate to discuss how pathological processes including inflammation, neoplasia, and infection relate to gastrointestinal and hepatobiliary tissue. How does inflammation relate to gastrointestinal and hepatobiliary tissue? Consider acute and chronic inflammation, cellular infiltration, tissue damage, vascular changes, loss of various functions. In esophagus, consider changes within mucosa and smooth muscle, inflammation cause of erosion, ulceration, infiltration by immune cells, neuromuscular dysfunction, impact on functions such as impaired peristalsis, stricture, dysphagia. Stomach, consider changes within parietal, chief, surface mucus, and enteroendocrine cells leading to atrophy of glands, loss of acid or enzyme secretion, intestinal metaplasia, impact on functions such as reduced production of HCl, pepsin, impaired digestion, B12 malabsorption. In small intestines, consider enterocytes, Paneth and goblet cells, villi atrophy, increased permeability, loss of antimicrobial function, impact on functions such as malabsorption, chronic diarrhea. In large bowel and appendix, consider enterocytes, goblet cells, lymphocytes, mucosal damage, increased mucus production, activation of lymphoid tissue, impact on functions such as impaired water reabsorption, bloody diarrhea, ulceration, stricture formation. In liver, consider hepatocytes and their damage or death, Kupffer and stellate cells and their activation, impact on function via fibrosis, cirrhosis, impaired detoxification, metabolism and bile production. How does neoplasia relate to gastrointestinal and hepatobiliary tissue? Consider nuclear features, cellular appearance, architectural changes in tissue, uncontrolled abnormal growth of epithelial cells, tumor formation, bleeding, polyp formation, changes in systemic metabolic functions. How does infection relate to endocrine tissue? Consider ulceration and tissue destruction, perforation, damage to mucosal cells, in esophagus candida and CMV infections, in stomach H. pylori infections causing peptic ulcers, in small intestine salmonella infection, in large intestine E. coli or C. diff causing diarrhea, in liver hep A, B, C leading to cirrhosis or cancer. The third learning outcome is for the candidate to explain when and why samples of gastrointestinal and hepatobiliary tissue need to be prepared prior to dissection, as well as how this should be done. How are gastrointestinal and hepatobiliary samples prepared prior to dissection? Consider orientation, weight, measure, inking, opening longitudinally, slicing. Consider sample types you might receive in your lab like biopsies, lobes, wedges, partial or whole organs and the difference how you prepare them. The steps might be specific to each department but consider SOPs, methodology used or RCPath guidelines. The fourth learning outcome is for the candidate to explain dissection, tissue selection protocols and block selection rationale for samples of gastrointestinal and hepatobiliary tissue, as relevant to your laboratory. How is gastrointestinal and hepatobiliary tissue dissected? What blocks are taken and why? Consider gross examination, description, slicing and opening, systematic sampling approach to obtain adequate representation of pathology, lymph node assessment, block selection, visible lesions or abnormalities, multiple blocks for larger tumors, assessment of resection margins, inclusion of normal tissue, specific anatomical landmarks like patches, lymphoid tissue, trainee E. coli, cystic duct margin, hilar margins, and so on. The steps might be specific to each department and each gastrointestinal and hepatobiliary organ. Therefore consider SOPs, methodology used and RCPath guidelines. The fifth learning outcome is for the candidate to describe how normal and abnormal gastrointestinal and hepatobiliary tissue stained using H&E should appear when viewed with a microscope. Use examples relevant to your practice. How would normal gastrointestinal and hepatobiliary tissue stained with H&E look like microscopically? Overall, insider mucosa, submucosa, muscularis externa, serosa, adventitia, and special features for each GI organ. For esophagus, consider non-keratinized stratified squamous epithelium with reedy ridges, GOJ junction, submucosal glands, muscularis externa transition from skeletal muscle to smooth to facilitate peristalsis. For stomach, consider simple columnar epithelium, gastric pits and specialized glands, muscularis externa third layer oblique to facilitate churning, basophilic chief cells for pepsinogen, eosinophilic parietal cells for HCl, mucous neck cells for protective mucus, enteroendocrine cells secreting gastrin, G cells. For small intestine, consider presence of simple columnar epithelium with microvilli, villi and crypts of Lieber-Kuhn, Brunner's glands, and Peyer's patches. Paneth cells that secrete antimicrobial peptides, enterocytes for absorption of nutrients via their brush border, scattered goblet cells for mucus production to lubricate food and protection, scattered enteroendocrine cells as chemosensors to regulate digestion. For large intestine, consider presence of simple columnar epithelium and lack of microvilli, crypts of Lieber-Kuhn, abundant goblet cells that secrete mucus for protection and lubrication, colonocytes for water and electrolyte absorption via inconspicuous border, enteroendocrine cells for hormone release to regulate gut motility. For liver, hepatic lobules, hepatocytes, Kupffer and stellate cells, portal triads consisting of hepatic artery, portal vein and bile duct, central vein, canaliculi, fenestrated sinusoidal walls and space of Dease. For appendix, consider simple columnar epithelium, abundant goblet cells, lymphoid tissue and lamina propria and submucosa. For gallbladder, consider lack of muscularis mucosa and submucosa. Mucosa has prominent folds, lined by simple columnar epithelium, Rokitansky-Askoff sinuses. Abnormal gastrointestinal and hepatobiliary tissue stained with HNE look like microscopically. In general, consider the changes in normal architecture and cellular organization, nuclei, cytoplasm, cell borders, mitotic figures, presence of fibrosis or cirrhosis, cell density, and so on. This is very specific to each organ and pathology. The sixth learning outcome is for the candidate to explain when and why special stains, IHC markers, and other specialist histology techniques might be required to demonstrate abnormalities of gastrointestinal and hepatobiliary tissue. Identify all the relevant stains and techniques. Why and when would special stains and IHC mark used to stain gastrointestinal and hepatobiliary tissue? Consider HNE and ambiguous morphology, for confirmation of differentiation, classifying tumors, identification site of origin, detection of specific proteins or hormones, evaluating prognosis, predicting treatment response. Special stains, AB-PA, AB-PAS to identify mucin types, PA and PAST for glycogen. GIMSA, Gram, or CN to identify infectious organisms, IHC stains, CK7, CK20, CDX2 to differentiate between adenocarcinoma and SCC, HER2 to guide therapy, MMR panel for Lynch syndrome, HEPR1, CA125, DOG1, SOL4 for subtyping and so on. The seventh learning outcome is for the candidate to describe the staining patterns you would expect to be able to view microscopically for each of the IHC, special, and other staining techniques listed above. Use examples relevant to your practice. What staining pattern would you expect to see on previously mentioned staining techniques? Consider normal and disease-related staining pattern, localization patterns like nuclear, cytoplasmic, membranous staining. Intensity of staining like negative, weak or strong, distribution patterns like diffuse, focal, or heterogeneous. The eighth learning outcome is for the candidate to demonstrate how you are involved in any part of the process between tissue preparation and reporting for a gastrointestinal and hepatobiliary tissue sample. What is your role in the process between tissue preparation and reporting for gastrointestinal and hepatobiliary samples? Consider pre-dissection steps like inking, opening, and your involvement during dissection, processing and the schedule used and why, embedding and any special instructions, microtomy and any special instructions, staining, QC, block check, digital scanning, and issuing slides to pathologists. This is very individual and depends on the training and competency of the candidate. The ninth learning outcome is for the candidate to discuss how cellular pathology investigations impacts the management of patients with gastrointestinal and hepatobiliary disorders. How do histology investigations impact the management of patients with gastrointestinal and hepatobiliary disorders? Consider benign versus malignant, in situ versus CIV, subtyping, grading, staging, tumor size and margins, lymph node status, lymphovascular invasion, guiding therapy via HER2 or MMR, monitoring progression of disease, prognostic value and value of digital pathology to share images, genomic profiling. Indicative content highlights knowledge and understanding requirements that might be assessed during the viva. They may or may not be demonstrated by the learning outcomes or candidate's evidence. In the gastrointestinal and hepatobiliary histology submodule, candidate is expected to have knowledge and understanding relevant to tissue processing and embedding techniques for routine histology samples. Relevant to EQA schemes for tissue processing and embedding procedures. Able to interpret and act upon the results. Resources section on the Brightspace contains some very useful information. Submission of evidence on Brightspace informs the candidate what evidence needs to be submitted for each subsection. Candidate needs to submit answers to questions that were set by the training officer. I will share some examples of possible questions later on. Candidate also needs to select an additional piece of evidence relevant to this subsection. I will also share with you some ideas of possible evidence later on in this video. Each submodule requires the candidate to submit their reflective statement relevant to their practice and training in each submodule. Questions should be set by the training officer. They need to be based around the knowledge requirements, relevant for each subsection. They should allow the candidate to demonstrate their understanding in each subsection. The questions should be specific and relevant to the candidate's in-house practice. They should also allow the candidate to demonstrate their specialist knowledge. If you would like to see specific example questions, please have a look at the video for trainers. Link will be included in the video description. These are some ideas you could explore for your chosen piece of evidence. And some more ideas for your chosen piece of evidence. Each submodule also contains reflective statement which is asking you, the candidate, to summarize your role in the laboratory in the context with each submodule. How do you demonstrate that you can draw conclusion from what you have learned, reflect on your current practice and how it can change in the future due to gained knowledge? Think about what is your laboratory in context this submodule. What impacts can your actions have on your colleagues, department as a whole and for the patients? You also need to write a personal reflection on your training and why you chose your evidence. This is very personal to your own circumstance. It should demonstrate your ability to be self-aware when analyzing the gaps in knowledge. You can use it as an opportunity to reflect on aspects of your training, application of your gained knowledge and skills, and how you have achieved your goals. Think about what your evidence demonstrates. Why did you choose this specific evidence for this submodule? Also write what your training was like when it comes to this submodule and how your practice changed due to your training. The reflective statements can also be used as a CPD evidence in case you are chosen to be audited by the HCPC. I would also like to share with you some helpful tips that can make your portfolio look really good. Try to present the information in various formats such as tables, pictures, photographs, diagrams, flowcharts, graphs or even videos, if you can. This nicely breaks down a lot of text that is usually present in specialist portfolios. Try to make it a little bit more interesting to the reader, which will be your training officer and eventually the assessor. Try to put yourself in their shoes. How would you like to read hundreds of pages of plain text? There is a saying I really like, and it goes like this: a picture is worth 1,000 words. I will make a video. I will share with you my evidence I used for my portfolio back in the day. Hopefully that will help. Also try to use various types of evidence, not just one type, like case studies, for each submodule. You could use experiments, case studies, annotated results, annotated photographs of you performing tasks, evidence of troubleshooting, annotated EQA results, nonconformances, validation and verification evidence, comparisons of different approaches and their pros and cons, control material production, certificates of course attendance with reflective statements, annotated images or charts, and so on. Try to bring in your personality. Think about the ways you like to learn best. If you like experimenting, perform experiment. If you like troubleshooting, perform troubleshooting. Choose something that demonstrates your understanding, knowledge, skills, and how you apply this in your practice. And one more thing, keep the learning outcomes in mind when you selecting your evidence. Good evidence will tick off several learning outcomes. And this brings me to the end of today's video. Hopefully you now have a better understanding about the learning outcomes for this submodule. And I hope you also have a better idea what evidence you can choose to demonstrate your competence. And my final take-home message? Keep those learning outcomes in mind when answering questions and selecting your evidence. Bye for now.